When we consider the cost effectiveness of CAR T-cell therapies, we need to consider the lifetime horizon of the effectiveness of these therapies. Some other therapies may require monthly administration for a long time. And then some of these other therapies may have a higher incidence of relapse. And we have to take into consideration the cost of continued administration of these therapies, the cost of relapse after the patient gets a relapse, and also the quality of life these patients suffer because of being on continued therapies. With CAR T-cell therapies, these are one-off therapies, and the patient is completely treatment-free after that for at least a long period of time, and some of these patients may be cured. So when we consider the lifetime horizon for the benefit of these therapies, CAR T-cell therapies can be more cost-effective. However, we have to consider product specificity and disease specificity. Certain products may be more cost-effective than other products, and they may be also more cost-effective only for particular indications. We also have to consider the incremental cost-effectiveness in different countries because the cost of living, the GDP per capita varies significantly between countries, and also we have to consider the price of CAR T-cell therapies in these different countries. So when we take that all into consideration, each country will have to do its own assessment of cost effectiveness for specific CAR T-cell therapies for specific indications. The main areas of differences in the cost effectiveness of CAR T-cell therapies for different indications are based on the results of the large clinical trials that have been performed for these particular indications for that particular product. For example, in second-line CAR T-cell therapies, one of the specific products has been shown to be significantly superior in overall survival and event-free survival in a long-term horizon. So when we calculated the cost effectiveness for this CAR T-cell therapy for the second-line indications for diffuse large B-cell lymphoma, it was found to be more cost-effective. For some of the products for other diseases like multiple myeloma, the effectiveness ratio was not so significant, and the cost effectiveness for these CAR T-cell therapies is still currently being worked out. Cost effectiveness can be improved through two things. One is by reducing costs and by improving effectiveness. Reducing costs can be done as we improve technology to be able to manufacture these cells more efficiently. Then we can significantly reduce costs. China is one of the leaders in trying to reduce the cost of CAR T-cell therapies. The other thing is to improve their effectiveness. If we can make CAR T-cell therapies more effective so that they are significantly better than the standard of care, that they can last longer and have less side effects, then in that case we can improve this cost effectiveness of CAR T-cell therapies. The use of CAR NK cell therapies allows us to use this in an allogenic setting, whereby one donor can potentially donate to several patients. This could improve the cost effectiveness if it reduces the cost of manufacture and the cost of administration for each individual patient. I'm interested and excited with results from, for example, Katie Rizvani's group from MD Anderson, which just showed highly effective CAR NK cells being able to eliminate tumor, as well as to be able to last for at least a year after transplant from these cord-derived CAR NK cells. I'm interested to look at more results for this so that perhaps this could be a novel, game-changing area of development in future.